Hello and welcome to this RPTH Research Recap. We are going to dive a little bit deeper into a recent publication in RPTH, and this is an exciting opportunity for us to highlight the World Patient Safety Day. So this is a great publication that will coincide with the emphasis on World Patient Safety Day. My name is Lena Castellucci, and I'm a thrombosis physician and researcher in Ottawa, Canada. And it's my pleasure to be here today with two of the co-authors from this exciting work, and I will introduce them each in turn. We have Dr. Sargam Kapoor and Dr. Andrew Pisecki. First, I'll introduce Dr. Kapoor. She did her internal medicine residency training at MedStar Washington Hospital Center at Georgetown University and her hematology oncology fellowship training at Case Western Reserve University in Cleveland, Ohio. She is currently an assistant professor of medicine at the Duke University in the Division of Hematology, and she practices classical hematology with a focus on thrombosis and hemostasis. She has an interest in cancer-associated thrombosis and conducts clinical research to study various aspects of this area. Our next presenter is Dr. Andrew Pisecki, who recently completed medical school training at Lake Erie College of Osteopathic Medicine in Erie, Pennsylvania, and he completed his internal medicine residency training at Indiana University, where he was appointed Quality Improvement and Safety Chief Resident after completion of his residency. He most recently finished his hematology fellowship training at Duke University Medical Center, where he was appointed Chief Fellow during his last year of fellowship. He has an interest in cancer-associated thrombosis with a specific focus of using anticoagulants in high-risk patients. Their recent publication is entitled An Epidemiologic Study Comparing Cancer and Non-Cancer Associated Venous Thromboembolism in Racially Diverse Southeastern United States County. It's my pleasure to welcome them here today so that they can share with us this exciting research and lead us more into what this means for our patients. Welcome to you both.
Thank you so much for that kind introduction. We'll go ahead and get our slides going here. All right, and thank you again. And Dr. Kapoor and I are excited to present our work, and we did want to acknowledge and thank the rest of the team here for their efforts with this project. We have no disclosures. We did want to acknowledge that the study was supported by the grant and cooperative agreement listed here from the Centers for Disease Control and Prevention. The findings and conclusions in this paper and presentation are those of the authors and do not represent the official position for the Centers for Disease Control and Prevention. So to begin with some background, cancer-associated venous thromboembolism, or VTE, is comprised of both the deep venous thrombosis and pulmonary embolism. Over here on the right, you can see a cartoon depiction of a left lower extremity deep venous thrombosis as well as a pulmonary embolism. Cancer-associated VTE is a common complication and important cause of morbidity and mortality in patients with cancer, with annual incidence rates at the interplay between patient and cancer-related risk factors. However, these annual incidence rates may overall ranges between 1.37 and 2.47 individuals per thousand each year, depending upon which study you look at. And the risk of finding malignant disease in a new venous thromboembolism diagnosis can be anywhere between 15 to 25%, again, depending upon which patient population you're studying. Cancer-associated VTE, again, can be due to cancer-related risk factors, which include the primary site of cancer. There's a higher risk of thrombosis with certain cancers, such as primary brain tumors, gastric, ovarian, and pancreatic tumors, as opposed to prostate cancer. There's a higher risk of thrombosis at time of diagnosis of cancer, really in those first several months, up to 6 months, even up to that first year. And there's a higher risk of thrombosis with extensive stage or metastatic disease, as opposed to more localized cancer. When it comes to our treatments, certain types are prothrombotic. Remember that Revlimid, tamoxifen, bevacizumab, to name a few, can all be prothrombotic, as well as the means to deliver cancer-directed therapies. Central lines can disrupt the endothelial membrane, and the negative charge of the lines themselves can activate the coagulation cascade, all of which can be prothrombotic. And lastly, we have patient-related risk factors as well. This can include increasing age, male sex, as well as concurrent medical histories, such as obesity, hypertension, smoking, sickle cell disease, and stage renal disease, to name a few, as well as race and ethnicity, which we will talk further throughout the rest of this presentation on. Next slide. But when it comes to race and ethnicity on cancer-associated VTE, there is a paucity of data in epidemiological studies on this area, especially in racially diverse counties. However, in the limited studies that are available, there appears to be a higher prevalence of VTE in Black or African American patients. So this begs the question, are these patients at a higher genetic predisposition? Some of our known inherited thrombophilias, such as prothrombin gene mutation, as well as the factor V Leiden, are more common in patients with Northern European ancestry. So perhaps there is a genetic predisposition in those with African ancestry that has not yet been illuminated. In addition to genetic predispositions, one has to question if there is more socioeconomic factors at play here. Do these patients have less access to healthcare? Are they presenting, are they unable to get their age-appropriate cancer screening guidelines? So they are presenting with more extensive stage disease that increases the risk of VTE, as we have seen on the previous slide. These patients have increased environmental exposure, such as smoking within their households? Do they have ongoing concurrent medical conditions that are contributing, such as hypertension, smoking, obesity, diabetes? And we do have to wonder, are these patients receiving lesser quality of care compared to some of their colleagues? So when it comes to some of the epidemiological data, we did want to point out one of these studies, which is done by Dr. Raskov and colleagues, published in 2022 in JTH. Dr. Raskov and colleagues looked at a racially diverse county in Oklahoma City, Oklahoma, where they looked at the annual incidence rates per 100,000 patient of a population of cancer-associated VTE. They looked at nearly 3,500 patients from 2012 to 2014. What they saw when grouped by race and ethnicity, that Hispanic patients had the lowest rate of VTE, followed by while non-Hispanic Black patients had the highest risk, and non-Hispanic white patients fell in between the two. Next slide. So we wanted to contribute to this limited epidemiological data on cancer-associated VTE in a racially diverse county, looking at our own county in Durham, North Carolina, from April 1st, 2012 to March 31st, 2014. For those of you who might not be familiar with United States geography, North Carolina is highlighted in red here in the southeast part of the country. And within North Carolina, Durham County is in central North Carolina, highlighted in blue here. And based upon the 2010 census data, the population estimates were nearly 270,000 people, of which most were non-Hispanic white, followed by non-Hispanic Black people, as well as 6% Asian or Pacific Islander people, with 15.1% were multiracial, unknown race or ethnicity, or other racial or ethnic population. So within our county, we looked at the Duke University Hospital, Duke Regional Hospital, as well as the Durham's Veterans Administration Medical Center. We based our findings based upon patients with ICD-9 or CPT codes based on pulmonary embolism, as well as deep venous thrombosis. Within these as well, patients were determined if they had active cancer, which is defined by having a positive pathology report for cancer and or having evidence of disease within the last 6 months or receiving active treatment. To determine all this, we used Deduce, which is a search engine software called the Duke Enterprise Data Unified Content Explorer. Through this search engine software, we were able to restrict upon geo-coded data for patients living within Durham County, and we were able to search from these ICD-9 and CPT codes to look for pulmonary embolism and deep venous thrombosis for people that were living in Durham County within the time frame that we have previously discussed. To show this further, again, from April 1st, 2012 to March 31st, 2014, we looked at patients with DVT and or pulmonary embolism within Durham County, which included a total of 987 patients within our total cohort, of which 798 did not have cancer and 189 did have cancer. Again, and in addition to our search software, we did confirm with manual review of electronic medical records, as well as autopsy reports to determine patient outcomes that were included within this timeframe. And we excluded patients who were living outside of Durham County during this timeframe. Now, I will hand it over to Dr. Sargon Kapoor to discuss the results in discussion sections.
Thank you, Dr. Pisecki, for that wonderful introduction to the background, rationale, and methods that we used in our study. I will now move on to the results. We analyzed the data gathered and compared baseline characteristics between the non-cancer associated VTE and cancer-associated VTE cohorts. we found that our patients with cancer-associated VTE or cancer VTE were older, had a lower BMI in comparison to the non-cancer VTE group. While there was no statistically significant difference in the overall racial distribution between the two groups, we did note a greater proportion of Black patients at 58.7% in the cancer VTE group, as opposed to 49.7% in the non-cancer VTE group. As for VTE event characteristics, we found that cancer VTE patients had a greater frequency of pulmonary embolism at 58.2% as opposed to 44% in the non-cancer VTE group. Similarly, PE only, that is PE without concomitant DVT, was found with increased frequency in the cancer VTE group. Interestingly, though, we did note greater symptomatic PE at presentation in the non-cancer associated VTE group as compared to the cancer VTE group. As would be expected from the above results, we did also note a higher frequency of DVT and DVT alone in the non-cancer associated VTE group, and a greater proportion of patients in non-cancer associated VTE group presenting with symptoms at DVT presentation. Given that the VTE risk really varies with the primary cancer site, we looked at the cancer VTE group and analyzed cancer type characteristics between the Black cancer VTE population and the white cancer VTE population. We noted that there was an increased proportion of Black cancer VTE patients with genitourinary malignancies at 25.2% in comparison to 9.6% in the white cancer VTE population. But otherwise, we did not note any statistically significant differences in other cancer types between the two groups. Importantly, we did not note any statistically significant difference in metastatic cancer between the Black cancer VTE population and the white cancer VTE population. However, of note, we did see that a greater proportion of patients in the white cancer VTE group, that is 78.3%, were on cancer-directed therapies at the time of VTE diagnosis in comparison to 60% in the Black cancer VTE group. We additionally looked at other VTE risk factors, including transient surgical, hormonal risk factors, treatment-related risk factors, and baseline persistent comorbidities. And I would just highlight what we found different was an increased risk of increased proportion of patients with recent hospitalization in the cancer VTE group. We interestingly found a greater proportion of patients in the non-cancer VTE group with a history of prior VTE at 20.4% in comparison to 10% in the cancer VTE group. Additionally, obesity defined as a BMI of more than 30 kilogram per meter square was noted more in the non-cancer VTE group at 51%. And smoking as well was greater in the non-cancer VTE group at 20% in comparison to 13% in the cancer VTE group. Moving on to outcomes, we first looked at survival outcome on these Kaplan-Meier curves in our entire VTE cohort, and essentially noted that the survival outcomes were essentially significantly worse in the cancer VTE population shown here in red in comparison to the non-cancer associated VTE population shown here in green. Subsequently, we looked at survival outcomes within the cancer VTE cohort and noted a significantly worse survival in Black cancer VTE patients shown here in green in comparison to white cancer VTE patients shown here in red throughout the duration of follow-up of the study. On the flip side, we did not note any statistically significant differences in survival outcomes between Black and white patients with non-cancer associated VTE. In summary, through our study, we showed that cancer VTE patients in our study were older, had a lower BMI, in contrast to their non-cancer VTE counterparts. Among patients with cancer VTE, PE was more prevalent than DVT. Cancer VTE patients had a lower survival compared to non-cancer VTE. And finally, among patients with cancer VTE, Black patients had a lower survival compared to white patients. I would now like to draw attention and highlight some of the key takeaways from our study. An important strength I would like to highlight is that we studied a racially diverse population in Durham County, which is much needed given the association between cancer and thrombosis is still less well understood in racially heterogeneous populations. As was outlined previously, we utilized a meticulous surveillance program. Our cohort is well representative of the racial heterogeneity in Durham County, with 51.5% Black and 45.8% white patients in our VTE cohort. We additionally also noted that our cancer type distribution was similar to what is described in documented cancer incidence rates. And finally, I would like to emphasize the racial disparities that we note in our study in cancer VTE survival outcomes, which is consistent with some previous literature, but not previously noted in a recent nationwide VA study, which suggests the possible role of socioeconomic determinants of health, access to healthcare, and its role on cancer VTE outcomes. A key limitation of our study is the study time frame. Our surveillance study was between 2012 to 2014, and hence different anticoagulant practices and cancer therapies were prevalent at the time. This is a retrospective study and hence comes with the risk of selection bias and incomplete documentation. As with epidemiologic population studies, race was self-reported. We were unable to compare baseline comorbidities in white and Black populations within the cancer VTE group, given the small sample size. And finally, recurrent VTE and bleeding outcomes data was also unable to be compared between the two groups, given small sample size in the cancer VTE population, as well as further loss to follow-up and death. Here are our references, and with this, I would like to thank the organizers for the opportunity to present our work and the audience for their attention, and I would like to open the floor for any questions for the two of us. Thank you.
That was wonderful. Congratulations to you both and to your team for this exciting work. It really does lend itself to adding information on this a really important topic because we don't have much information based on racial differences in the cancer and non-cancer populations. I wonder if you could tell me a little bit more about why you chose 6 months as your time frame for cancer diagnosis. And I ask that because in some of our more recent clinical trials, they maybe used a longer time frame for the diagnosis of active cancer. And I wonder if you can tell us why you chose a 6-month period.
I could go ahead with that question. So the question is why the 6 months duration was chosen for the definition of active cancer associated VTE, I guess. So my understanding is that active cancer is essentially, and I believe this is the ISTH definition, that within 6 months of a positive pathology report or positive evidence of disease, cancer burden on imaging, or current treatments is the definition of active cancer, which is why we went ahead with that definition.
Great, thank you. And I think you touched on a really important point about how the information on race is self-reported. And I wonder if you could also comment, Andrew, I'll ask you if you could comment, if you were to look at the Durham region today, what would the demographic be like today in comparison to that time period in 2012 to 14?
Yeah, and we did look at that, that Durham County is still a very diverse county. And even if you compare our rates of non-Hispanic white, non-Hispanic Black, Hispanic patients, Asian or Pacific Islander patients, Durham County is more diverse than the rest of the United States when you kind of compare it as a whole. So, these rates are consistent. We still have a very heterogeneous county when looking at the most recent census data, which was important to us because we wanted to ensure that that this patient population is still represented appropriately with our study.
That's great. Thank you. I'm going to take advantage of this being World Patient Safety Day and ask you guys a question about, you highlighted that a fair number of patients had been admitted to hospital in both groups prior to their VTE diagnosis. And I wonder if you could comment about use of risk assessment models at the time for VTE prophylaxis, if you have that information, or if you even want to share what you currently do in your hospitals for risk assessment of VTE.
I would like to share a slide to answer that question, actually. Are my slides still visible? So I do not have access to sort of the algorithm that was used back in 2012 to 2014 in terms of what the VTE prophylaxis inpatient, the strategies and algorithms around that were. But I would like to share here. This was the data that we got from hospitalized patients with VTE, without and with cancer. And essentially, I would like to highlight that we could do better with thromboprophylaxis at the time of VTE diagnosis. We noted in both groups, in fact, even in the cancer-associated VTE group, less than half of the patients were on VTE prophylaxis at the time in their inpatient status. So we could certainly do better in terms of inpatient thromboprophylaxis. I do not have the numbers, the current statistics on that, how we are doing in terms of inpatient thromboprophylaxis. However, that's kind of what the future direction is. We would need a current, maybe larger study to explore all of these current practice patterns.
That's great, thank you, Sargam. And Andrew, maybe I'll ask you to talk about what your current risk assessment model is like in your hospital for patients admitted to hospital.
Yeah, of course. So, and Sargam, feel free to hop in here as well. So I think it depends upon the patient and what their cancer diagnosis is. Focusing on that, and there's certain post-surgical risk assessment tools, PADWA, SCORE, for example, Caprini, which are used for thromboprophylaxis in that post-surgical setting as well. And Sargam, are there any other ones that you tend to use as well?
No, I think I tend to favor the Caprini score, and that is one of the current endeavors that we are trying to work on developing a risk assessment model for, addressing these high inpatient VTE rates, and as well as in the post-op setting. So that is something that we really need further work on.
That's great. Thank you both for that. I'm going to ask you a little bit more about some of the other outcomes that you talked about, in particular, all-cause patient mortality. And I know you chose all-cause mortality possibly because it's difficult for us to determine PE-related mortality. Sometimes we don't have access to autopsies, for example, and so I wonder if you are able to share any of that information about potential PE-related mortality. In particular, one of the tables in your manuscript was actually quite striking about the timing of deaths related to when the VTE was diagnosed. And in the cancer population in particular, the majority of the deaths occurred in that 6 months after VTE diagnosis. And I wonder if you could comment on that, and if you think some of that may have been related to PE mortality, but we simply weren't able to capture that. Sargam, I don't know if you want to tackle that?
Yes, for sure. So the question is about all-cause mortality and whether we know anything about mortality related to PE in itself. And I'm trying to bring up a slide here, which here, this one, I believe this is probably what you're referring to with the all-cause mortality. And of course, the sort of what this slide essentially shows is that up here with cancer patients, we saw that there were 19 deaths in the, 189 or so patients in the first 7 days. And then subsequently, within the first sort of 1 week to 6 months mark, we had 73 deaths, and for a total of 107 deaths during the duration of follow-up of the study. So these are all-cause mortality. And of course, it's hard to say whether this was, what was at play. Was it the metastatic cancer? Was it therapy-related side effects? Was it PE or DVT or anticoagulation related bleeding outcomes and so on and so forth? I do not have that data. We did not delve into sort of specifically PE related mortality or VTE related mortality.
Thank you. And Andrew, did you want to add anything there, or are you okay?
I would just kind of echo what Sargam said, and then just kind of show how much morbidity and mortality this cancer-related complication can cause. And it's clear that we weren't able to further delineate the exact etiologies of these deaths, but it's clear that these patients who have thrombosis with their active disease are very, very sick and truly need proper treatment.
Absolutely. And one of the other striking features that I found on this table was, although the proportion of deaths in the non-cancer population was certainly lower, you can see that the timing of death is actually similar in that it's higher in that up to 6 month period. So that first week to 6 month period, it's higher in the non-cancer population as well as the cancer population. And so I wonder if this is simply a marker of VTE being a prognostic indicator of subsequent all-cause mortality in the entire population. And this leads me to my next question for you. And you may not have looked at this, but I think it might be something to consider if you do a subsequent study on this. In your current non-cancer patient population, was there any look to see if subsequent to their VTE diagnosis, they were diagnosed with cancer within the year subsequent to their VTE diagnosis? And perhaps you guys could comment on that.
Yeah, it's a great thought. And Sargam, feel free to hop in here if you knew that literature. I don't believe we looked at that in the time frame that we collected this data, but it certainly is an interesting point, and one that I think is well worth investigation to see if it is a prognostic marker for future cancer for these patients.
I echo with what Andrew said. That would be interesting to see.
Awesome. Yeah, I think it would be kind of cool to look at, because we know that maybe in the unprovoked VTE population, there's that 5% risk of underlying malignancy. So it'd be cool if you guys could come back and share that information with us. That'd be awesome. I'm going to thank you both for your time here. And I just want to give you both an opportunity to tell us, what do you think your next steps are going to be? What's your next part of this project? Go. Sargam, I'll start with you.
Yes, thank you for that question. So I think a next step would be a larger study, a more current study, more relevant to the current anticoagulation practice patterns and current cancer therapies. Cancer patients are living longer, so the data could be very different. So essentially looking at, also other, newer therapies, immune therapy, targeted therapy. We know so much more about mutational status of cancers and mutational burden and so on and so forth. So looking at all of that as sort of a next project and see how that's relevant to the current times.
Great. And Andrew?
Yeah, I think Sargam nailed it. I think it's really interesting to see, as we are getting more and more genetic information about these patients' tumors, looking at the allele burden and seeing if there are racial differences within that, perhaps in addition to socioeconomic factors that we weren't able to obtain too much of during our study, but collecting that data in addition to just insurance stats, but perhaps a household income if available, or other socioeconomic factors that could play a role, in addition to trying to really illuminate that perhaps genetic predisposition for Black or African American patients, that there appears to be a signal that they may have a higher risk of cancer-associated VTE. So really trying to illuminate that, and perhaps looking further into the genetic predisposition in addition to socioeconomic factors.
That's great. That's really exciting. I look forward to reading about your next steps, and I hope we get to do this again at some point in the future. I would like to thank you both for taking time to share your exciting research study with us. It coincides really well with World Patient Safety Day, and I think it brings to the forefront our need to do a risk assessment for our patients with cancer, even without cancer, especially when they are admitted to hospital. And, I think, Dr. Kapoor, you said it very well. We can do better for VTE prophylaxis, and I think this really highlights that. So thank you both for being here. We can see your exciting work on rpth.org and rpthjournal.org, and we look forward to next steps and hearing from you soon. Thank you.